Thank you so much, Elizabeth. Okay, so I have one disclosure to make. You can all leave now because everything I'm going to say, you've heard it in one version or the other before. But if you choose to stay, this will be over in a few minutes, so bear with me. And thank you all for, hanging out and still being here. We truly appreciate it. It's been an excellent, excellent meeting, and I really, really thank the organizers, particularly Serge, for the very kind invitation. So why is hydroxyurea first-line therapy in the US for ET and not anagrelide or interferon? To put this in some context for you, if I can advance my slide. Mouse in. Okay, let's see. Maybe that's a clue that the talk is over. I see it, and now it works. Okay. All right, so these are my disclosures. I serve on the advisory board for a number of pharmaceutical companies that are shown on the slide, and I don't think any one of them is involved in marketing any of the agents that I will be talking about. So to put this in a little bit of a context, I think you've seen a version of this slide before, but this illustrates a couple of points, I think. One is that ET patients still have a relatively inferior median survival in contemporary series compared with age and sex matched controls shown in the black line. The ET patient survival is shown in the red curve. The other point it also illustrates, of course, is that compared with the other pH-negative MPNs, though, ET patients enjoy a relatively long life. That means that we have room for improvement. We need to try to get the survival similar to that of their non-affected counterparts if we can. And at the same time, we have to avoid doing things that will be harmful and will worsen their otherwise relatively decent life expectancy. And along the lines of natural history, this also goes to show that the incidence of blast transformation in patients with WHO-defined ET is relatively low compared with, say, patients with primary myelofibrosis. And so when is a cytoreductive agent necessary in ET? You've heard this reinforced, in many different ways, along the course of the day. So the therapies in the past were toxic and leukemogenic, so talking about drugs like radioactive phosphorus, etc., as in the trials conducted by the PVSG in PV. So that raised the level of caution in terms of initiating cytoreductive therapy in an MPN patient, like an ET patient who would otherwise enjoy a relatively long life. You've also heard repeatedly, reinforced in various ways, that the degree of thrombocytosis does not appear to be predictive of thrombotic risk. So treating a patient just because of their platelet number is something we're no longer doing. And that there are two factors historically that have been predictive of thrombosis, and that includes age over 60 and a history of prior thrombosis. And arguably, those are the more common reasons why most of us would initiate a cytoreductive agent. And of course, that extreme thrombocytosis, right, is associated with acquired von Willebrand disease, associated with hemorrhagic complications. So you've heard this too, which is that in today's day and age with molecular profiling, we know that if you're JAK2 wild type with ET, you have a superior thrombosis risk survival compared with those who have the mutation. And that's now been incorporated into a risk scoring system for predicting thrombotic risk in ET. One of the interesting issues about this, risk scoring system, I find is the question of how, broadly applicable this might be, and is this something that we should be integrating into our everyday clinical practice in a more broad fashion. And you've seen slides from prior colleagues discussing, current recommendations that are not clearly evidence-based about how we could integrate the IPSET scoring system into the treatment of patients with, or like when to start cytoreductive therapy. So interestingly, when you look at this, for example, someone who is older, but who has no cardiovascular risk factors and who does not have a JAK2 mutation and who's never had a prior thrombosis would be low risk and would not be a candidate according to this, if we went strictly by this, for cytoreductive therapy. And whether any of us would feel that comfortable at this point, I think, is debatable. It would be nice to have prospective evidence. And this, of course, shows that this was validated externally, and we've discussed the implications. So choice of cytoreductive agent, which is really what my talk is focused on. What's the evidence? The arguments in favor of the use of hydroxyurea are that there is data, and Brady presented that very elegantly in favor of leukocytosis being associated with thrombosis. The strength of the association, at least retrospectively, was reduced by hydroxyurea use. Prospective results from a trial that many in the audience are familiar with, the UK PT1 trial, support the superiority of hydroxyurea. And I think on the basis of the results of this trial, most would use hydroxyurea as frontline therapy. And to remind you of the results of those trials, right, this was a fairly large trial where patients were randomized to hydroxyurea plus aspirin versus anagrelide plus aspirin. And with regard to the composite primary endpoint of arterial and venous thrombosis, serious hemorrhage, and death from these causes, the hydroxyurea plus aspirin arm was superior. The other interesting point one can make from this study is that the platelet control over time, after the first 6 months, where there was an initial difference in the first 6 months, hydroxyurea controlled the platelet count more rapidly, but thereafter there really wasn't much difference at all in the two curves, as you can see, between these two arms. And so it's hard to say that control of the platelet count in this study was what made the difference. And when they looked at the hydroxyurea plus aspirin arm, it was superior in prevention of arterial thrombosis versus the anagrelide plus aspirin arm. And interestingly, though, the survival free of venous thrombosis, as many of you know, was superior in the anagrelide plus aspirin arm. So, there's that open issue of, for venous thrombosis, which is the better agent, according to this study, the anagrelide arm fared better, but obviously we all fear arterial thrombosis. And And in terms of the complications from the use of these agents, or rather in terms of their ability, I should say, to modify natural history, plus or minus complications, there was an increased rate of transformation to overt myelofibrosis in the anagrelide plus aspirin arm, and this has been the subject of much additional debate as to why that was the case. The incidence of serious hemorrhage was also more common in the anagrelide plus aspirin arm, and you have to remember again that this wasn't a trial of hydroxyurea versus anagrelide. It was a trial of hydroxyurea plus aspirin versus anagrelide plus aspirin, and there is a potential concern that the use of both agents, anagrelide and aspirin together, could have contributed to the increase in hemorrhage in the anagrelide arm. So, how do we explain the results of this trial? Well, one explanation is that hydroxyurea is, simply superior to anagrelide, and that this may be because of its effects as a general cytoreductive agent, right? It also reduces your white blood cell count, or it could be that there were other confounding variables which many in the field have raised. The prime one being that the diagnosis of ET in the UK-PT1 trial was made according to the PVSG criteria, and therefore prefibrotic MF was included, and that this skewed the outcome, because we know from subsequent publications that prefibrotic MF has been associated with an inferior outcome compared with patients with true ET according to the WHO criteria, primarily with regards to the issue of thrombotic complications as well as progression to overt fibrosis. So the other issue is that this PT1 trial also included patients who had previously been on hydroxyurea. This wasn't a trial where patients came in, never having been on a cytoreductive agent, so there was a washout period where, the counts, would have risen in those who were initially on hydroxyurea. So to address those concerns, we can look at the results of the anhydride study, which was a study where anagrelide was compared with hydroxyurea in WHO classified ET. If the criticism is that in the other trial, the results were inferior because of the fact that ET was defined according to the PVSG criteria, what about if you were to do a trial where patients with prefibrotic MF were largely excluded? What would the results look like? And so this was a smaller study with about just approximately close to 250 patients randomized between the two arms. And this showed that the title is a little bit off here, but this slide shows that the anagrelide and hydroxyurea arm were equivalent with regards to the platelet count and more or less with regard to the hemoglobin. So there wasn't much of a difference. The title is meant for this, which shows clearly that in the hydroxyurea arm, the platelet count significantly decreased right after about 3 months. You can see in the lower curve, which is the hydroxyurea arm, the white count was significantly lower and remained so for the duration of follow-up. But the other thing that is interesting to note here is that the median white count here is in the 10 to 11,000 range, so relatively low. And this may be more typical of the hematologic indices that one would see for true ET. The diagnosis here was reviewed centrally, and there was more than 80% concordance with regards to the diagnosis of ET in a blinded fashion between pathologists according to the WHO criteria. And so in that subset of 83% roughly of patients who had a true ET diagnosis, the two arms were equivalent. So anagrelide, this was designed as a non-inferiority study, and anagrelide was not inferior to hydroxyurea with regard to ET-related thrombotic or bleeding events. Looking at the study population as a whole also, there wasn't any sort of significant difference according to their predefined statistical endpoints. So hydroxyurea and anagrelide may be equivalent in WHO-defined ET, but how easy is it to make that diagnosis? And we'd say that, going back to the previous slide, so ET, the diagnosis of ET remains largely a diagnosis of exclusion, right? You have to rule out many other causes, and one of the ones that of thrombocytosis, and one of the ones that's harder to do, as alluded to in previous talks. I think I remember Brady touched on that, was, and so did Elizabeth, was the issue of primary myelofibrosis. So when a patient has overt myelofibrosis and they have all these criteria, it's fairly obvious. But in the prefibrotic phase, where fibrosis is minimal compared with overt fibrosis, you can see that the bone marrow looks very different morphologically, and one wouldn't be shocked if a patient with prefibrotic myelofibrosis were diagnosed as true ET. One of the major diagnostic differences is in the megakaryocytic morphology. In institutions like ours, sometimes I wonder when I'm going to find an ET patient, because I have so many patients who sent to me with a diagnosis of ET who get reclassified as prefibrotic MF. But in the, I think, larger sort of, practicing group community of hematologists, I think this is not that straightforward. The folks, the European group, Peter Campbell's group, in a study that they published a few years ago, several years ago now, the concordance rate between their pathologists in terms of trying to distinguish these two entities from the megakaryocytic morphology standpoint was as low as 50%. So it's not an easy diagnosis to make. The other comments to be made about the anhydride study was that there was no aspirin used, and so the thrombosis rate overall was higher than what we would have expected in terms of the natural history of ET published historically. And those findings, of course, suggests aspirin is important in ET. But when added to anagrelide, the question is, will it increase bleeding complications similar to observations made in the PT1 trial? So there are lots of open questions. But both agents were quite tolerable, and there was no evidence of MF transformation or leukemic transformation as being a problem with either of these. With the use of hydroxyurea, the issue of leukemogenicity is one that's repeatedly raised. The evidence, there isn't any good prospective evidence to go on, as many of my colleagues have said. One of the studies that I find relatively compelling is actually extrapolated from the ECLAP trial. So these were PV patients, not ET patients, and there was no evidence, retrospectively at least, that those patients had an excess of leukemia. So interferon, I'm not going to belabor the point because it's been talked about a lot in PV, how effective it is. In ET, Dr. Vestovsek's group has shown, as well as others, a high CR rate. And we know that in PV, as well as to some degree in ET, that it may selectively affect the JAK2 clone and permit an outgrowth of normal wild-type hematopoiesis. And the side effects, have been alluded to, but they are much better with the pegylated formulation. Neuropsychiatric side effects I worry about. So if someone's depressed, they're not a candidate. So Hydroxyurea remains the standard of care, or the front line here, because of the PT1 results. In my view, they are relatively compelling, and we can debate about the WHO true ET population and what the results would look like if we had a big study in that. But the difficulties for extrapolating that in the real world setting. And anagrelide maybe is reasonable if you're sure the patient has true ET, but then there's the whole idea of aspirin and maybe increasing bleeding risk, etc. So I think that prospective validation in larger trials is desirable. And interferon, we have talked about how this may modify the clone somehow, but the short and long-term risks are worth evaluating prospectively. Randomized data would be helpful in that regard, and you have already heard of the trial here that's ongoing in the US. There are also trials ongoing in Europe, trying to answer the question at least of Hydroxyurea versus pegylated interferon in high-risk PVO and ET. Those are worth supporting. Thank you for your attention.